The next man needs very little introduction, if you were there at our storytelling event. If you weren't, you've missed a surgeon slayer. Ian Summers heads up the simulation centre at Monash in Melbourne. And today, with this cast of many, many friends, he's going to take you through some of our most challenging conversations and how we can learn from each other to be better at communicating with our patients and our families. Ian.
Thanks so much, Andy. Welcome in. During the storytelling event, we tried something and it worked quite well. And I'm suspecting that it might be a couple of stragglers that are still in the lunch area that we were going to try and drag in. So you've all seen the buskers in Melbourne or somewhere else that have had this applause that goes frantic for about 30 seconds and then stops. We're going to do exactly the same. We're going to make so much noise that we're going to drag people out of the other session and try and fill this room. Is that okay by everybody? So if you start slowly and then build it up to full volume over 30 seconds, when I do that, I just need complete silence. Are you ready? 1, 2, 3, go. Oh, that's nice. So what you're really doing is applauding the people that are going to be joining me on the stage today, and are going to be thanking them for taking the time to come to us, but also putting themselves out there a little bit. So they're going to have some challenging conversations on the stage, but the challenging conversations they're going to have are a little bit odd. You don't usually have these in front of a stage. You don't usually have these as a fragmented moment of time, and you don't usually have some sense of warning about what's coming, but sometimes a little bit of surprise that I might throw in, because I quite like simulation and I quite like throwing surprises around. So some of the panelists know some of the things I'm going to ask, and an occasional one I've just got tucked away in my back pocket. The other opportunity is for you to sit in the audience and think, oh, actually there's a conversational topic that I find challenging, and if we've got time, I just want you to launch them out to the roving microphone, and we'll use the expertise of this group to try and solve them for you. Becky's looking at me horrified. She goes, I didn't know that was up for the grabs. Yes. So what we've got at the moment is a red chair here. That represents the chair of the clinicians. Let's call it the hot seat for the sake of the fact that it's red. And we've got this other chair that's the chair that is going to be filled by one of the parents involved in this conversation. And so I'm not going to introduce Becky except to say that she's the mother of a child. Sarah, can I get you to introduce yourself to anybody that missed the first 2 days?
Mm-hmm. Well, I'm going to do it with Becky, but I'm Sarah McNab. I'm a paediatrician by background.
Okay.
That's it.
That was a CV that is that long condensed to that, but that's okay. We can respect that. So for the sake of today, Sarah is doing a ward round where she's come on into intake to see a child who is, how old is your child, Becky?
She's 15.
She's 15 years old. And Becky came through the emergency department yesterday with a seizure. And it was a seizure that was in some ways atypical. She had a CT scan, she got admitted to the ward, and you're meeting mum for the first time. Now, Sarah's been through a history and examination process and has built rapport in the way that Sarah normally would, and is now focusing on a little bit more of that crossover into the discussion about diagnosis. Is that okay by you, Sarah?
It's fine.
I'll leave it to you.
Hi, Becky. So what's your understanding of where we're at the moment?
I'm going to be honest, I'm a bit baffled, to be honest. We came in yesterday. Emma had had a seizure at home. It was awful to watch. You know, that I don't think any parent should have to watch that. I know it was a seizure because her cousins had seizures before, and so I've seen them. And then it happened again when we got here, and that was when she had the head scan. And so I thought that somebody would start her on some medication or something to stop it happening again. And then all these different words have been used, but I overheard somebody saying pseudo-seizure. I know what pseudo means. That means false, and And now I feel like people think that she's somehow faking it, that it's not real, and it is real. I've seen it.
Yeah.
And you know, she's living with this. I don't know whether I'm coming or going.
Yeah, that sounds really difficult. I'm sorry that's what you've been through. I don't think she's faking it. Okay. But I do.
Does that mean she's epileptic then?
No, I don't think that these are epileptic seizures. Okay. I think what Emma's experiencing is something that we call functional neurological disorder. Okay. It has been called different terms, and pseudo-seizure is not a term that I would use, but it is a term that has been used. Okay.
Okay.
Functional neurological disorder, it's where the structure of her brain is okay. So the electricity or the connections between the brain are okay, the hardware, so to speak. But the messages that her brain is sending the body is making her have these episodes that look very much like seizures. Okay. But the brain structure itself is okay.
So why is it happening then? Because, you know, what if it happens when she's not with me? What?
Yeah.
I don't know what to do about this. Why is it happening?
Yeah, it's scary to look at. You've experienced this. It's very scary, and it might happen when she's not with you. In general, people who have these episodes tend to not do them in a place which will be unsafe, like in water.
Like she's got some control over it then?
No, it's a bit more complex than that. There are some subtypes where there can be an element of control, but what is much more common is that it's not deliberate. She's not faking it, but her brain is sending really strong messages to her body to do these movements. It's a little bit like anxiety. So when you've got anxiety, you might get butterflies in your stomach. Okay, they're really real symptoms, and you can't control the butterflies in your stomach. Okay, but there's nothing wrong with your stomach at that time.
No, but she's not anxious.
No.
Everything seems fine.
I'm just going to stop there. Is that okay, Sarah? We've done enough. So thank you. I think applause is warranted. Sarah, do you mind if I get you to sit just on the seat next to, just to now take you out of the role of somewhat artificial discussion of that disorder? And I'm going to be asking Becky, and you didn't know I was going to do this, but I am going to get you asking Becky her opinion on what just happened as well. But go to you first. Was there anything there that you found particularly difficult?
All of it?
All of it?
I find this conversation really, really tricky. Always, and
yes.
So, which is probably why Ian asked me to do this scenario, for a few reasons. I mean, some of it is the artificial. Usually what I would do is get to know a family a little bit more through the history and examination and know how to pitch the conversation. I word this conversation differently pretty much every time, and sometimes fudge it a bit, where that whole water thing, I wouldn't normally say. I kind of went down a little rabbit hole there.
Yes.
But then it's taking a breath and trying to find your way out of it. I think I've gone too deep now. I'm just still getting over the adrenaline rush of having to do that in front of all of you.
Yeah, it's strange. You don't usually have 100 strangers all watching in as you have this very private, very emotional.
Well, you do have a ward round often.
Yes.
Yeah.
Okay.
Yeah. And analogies are always hard because I wasn't trying to say she was anxious. I was trying to use an analogy. So, yeah.
Okay. So I hadn't realised that this would actually happen during a ward round, this discussion. Is that right? Okay.
Often. Is that... Yeah.
Yeah? Okay. So, I mean, that would seem to have pros and cons. One is that your juniors are listening. And we might talk about the significance of that, but that often seems to be a way that, particularly in emergency medicine, this is often me and somebody else in a room with nobody either observing to give me feedback or observing me to learn from me as well. So that in itself is interesting. Becky, how did you find it as mum?
I think as mum, the confusion had arisen because I thought she was having a seizure, And then I've heard somebody allude to the fact that she might be faking it. And so there's confusion, and there's also a defensiveness there because of that. But Sarah just completely cut through that straight away by saying, I don't think she's faking it.
Yeah.
And I think that's a really powerful thing to say, because number one, it reassures me that nobody's accusing my daughter of putting this on. And it also says that she's taken it seriously.
Yes. Great. And so much what we often focus on, I think, is the words that are said. And I think probably we'll get this as a bit of a rhythm going through, that often, in fact, what I observe and what gets created is the space for you to speak, so that then the concerns are addressed directly to the listening that's being done. And I think we undervalue that skill, or undervalue it sometimes. Is there anything more that either of you wanted to bring up before we go into the next topic, the next section?
I think about these conditions specifically, one thing, and we talked about whether we should do this or not, is that sometimes the diagnosis is not clear straight away, and you do want to do some investigations, but you suspect that it might be a functional neurological disorder, but you want to rule all of these things out before you bring that to a family.
Yes.
And one thing that I learnt some years ago was that there is real power in, we decided we weren't going to complicate the scenario because we don't have time by doing that type of scenario, but there is real power in using the diagnosis up front as a differential. So rather than saying, okay, we're going to do an EEG and we're going to do an MRI and we're going to do this and this, and then a few days later going, all of those are normal, and therefore what we're left with is functional neurological disorder, is potentially saying in the first consultation, well, I still want to do an EEG, but I think the most likely thing is this. Or even if it's not the most likely, there are a few differentials that we're looking at, epilepsy, functional neurological disorder, and whatever else might be on the table. So rather than having it as we ran out of things to investigate diagnosis, as a real positive, and I use positive in inverted commas up front.
And that seems to be a common theme that emerges, is there's a planting of a diagnosis or an idea that gradually builds momentum over the course of exclusion. And I think that's, again, the disadvantage of having this little short snapshot, is let's acknowledge that, because I think that's a great way to build that momentum of actually, there's no sudden moment, it is an emerging theme that comes through. There was something that I loved you talking about, which is the butterflies in the stomach. I've never heard that before. Why do you use that? Tell me a little bit more about that idea.
Is Natalie Morgan here? She taught me that. I think I use quite a few different analogies in different contexts, but I like that idea that there is something that everybody can relate to, right? That sort of, although not perfectly, describes the idea that your brain is a really powerful weapon that can do really weird things to your body, even where there's not a physical reason. I mean, there are maybe, some sorts of physical reasons why that happens, but it just feels like a simple one for families to understand, although Becky kind of took that on a slightly different tangent to take the analogy literally, and you have to be careful of that with analogies.
Okay. And I think probably it also brings up the opportunity to go a little bit deeper as to what's going on in life at the moment that produces the butterflies, or in this case, the non-epileptiform seizures. So it's opening up a nice topic as well. Thank you both so much. So for the audience, I guess one of the reasons that I wanted this session to run in a way that it has is I'm a predominantly adult emergency medicine physician now, seeing a small fraction of my life as being paediatrics. And I'm keen to learn from the people here. And it's almost like I now have a little jot note. Oh, butterflies in the stomach, like that one. So can I encourage you, as you're listening, to take little snapshots of the things that you love, and use this as like a collection moment of wisdom of the people that are in this group that are coming. There's probably 100 years, I'm guessing, of emergency medicine and paediatric experience coming on in this stage. So
Thanks
Hang
so
on,
much.
hold on.
Rob and I are about 60 years between us, but that means that we've had a chance to make a lot of mistakes over our years. So probably I might even actually ask them about some of their mistakes as well. So you might as well learn from us rather than go through the learning process as well. Admittedly, we're still making mistakes. So as you're watching, if you see stuff you don't like, let us know. There is the opportunity to tweak the things that we're doing, and we're open to that as well. But what I wanted to do, if it's okay with you, is switch. So Becky, you're now into the role of clinician. Your next patient is coming up. Sarah, I'll get you to sit beside me. Becky, can I give you the chance to introduce yourself now in your real role for those that haven't had the chance to see you yet?
Yes, my name's Becky Platt. I'm an advanced clinical practitioner at the Royal London. For those of you who don't know what an advanced clinical practitioner is, so fess up, I actually have got 25 years of nursing experience. And I now work in an advanced clinical role, which is kind of on the registrar rota, so it's a kind of hybrid thing.
Great, thank you. So the situation that we've got into is Sasha is the mother of a 7-year-old, is that right? 7-year-old boy, I've forgotten his name. David. And David fractured his arm and was brought in by paramedics. He got some intranasal fentanyl. He got a temporary splint put on. He's been x-rayed. He has a deformity of forearm of a fracture needing reduction. Is that about the sort of setup? And I think, Becky, you're meeting Mum for the first time. He was very quiet when he first came in. So the paramedics said right the way through, he hardly said boo to a goose. And at triage, there was a note about autism. Is that a fair setup? Great. Go for it.
Great. Hi, Sasha. I'm Becky. I'm an advanced clinical practitioner. So I just wanted to have a quick chat with you about David and next steps. Is that the kind of thing that we should do out of his earshot, or?
Yeah, I think that would be better. I think he's good with instructions, but I think giving him too much information in one go, he finds that quite overwhelming.
Oh,
is that okay?
Fair enough, yeah. So I understood from my colleague that he's got some additional needs, that he's autistic. Is that right?
Yeah, he's really good. He's high functioning, as in he's really articulate. He does really well with instructions, but in stepwise, so not too much information in one go. He does get sensory overload to lots of people at the same time. Is going to be a bit difficult for him. I mean, obviously we'll do what we need to do, but if we can, if you've got a plan of attack and I can explain it to him, I think we'll get to a better place than, bless him, last year he needed a line put in and it went badly. I think some of that was my fault. He had the medicine that went up the nose and he had the opposite reaction, and then it all fell apart, and then he ended up being pinned down, and I should have said, no, don't do that. And then, so he's doing really well. I think that's why he's quiet, because he's a bit worried.
Okay.
He's okay, like he's not aggressive, but he does need time.
Okay.
Is that, have we got some time?
That's fine.
Not loads,
Yeah.
just I need a bit with him.
Fine. So this is a procedure that we want to get done fairly quickly, because as I think you're aware, we want to get this fracture into a better position, so
Yeah, it
that
looks
it's going to
pretty
heal better. Yeah, it doesn't look great on the x-ray. It will heal absolutely fine.
Oh, good.
It's not so time critical that we have to do it in the next 30 seconds. So we have got some time to make sure we get this right. And I think, especially considering you had that bad experience before, want to get this right for him today.
That'd be good.
Do you want me to explain a bit about the actual procedure, and then we can maybe think about some options and what's right for him?
That'd be really good. If you've got the time, I think that'll make it, I'd like to make it, as much as hospital can be a positive experience, a decent one for him, because it's not his last time he's going to come here.
Yeah.
And I'd like to make it bearable.
Great. Okay. So as it stands, both the bones in his wrist are broken, and they're both, and they're in a position that is not best place for healing. What we want to do, and we can do it in the emergency department, is to get his wrist into a better position. Now, it's a procedure that's only going to take a few minutes, but it would be painful without us giving him, strong pain relief.
Okay.
And I think in his situation, for children of his age, we would normally give some sedation as well.
Okay.
which means that he won't realise what's going on, that will provide some good pain relief for him, and he'll have no memory of it. And I think, given everything that you've told me in his age, that's probably what we're looking for.
Okay. What kind of sedation do you think?
So
Okay, let's stop there. Is that enough,
Yep.
Becky,
Yep.
for you? Okay, again, I'll get you to sit across there just so that the audience can see you and appreciate you. How did that feel?
It felt fine, actually. This is a conversation that I have reasonably regularly in my practice.
Yes.
And this is a mum that's clearly open to the conversation. It's not an absolutely time-critical procedure. I don't have to get it done in the next 5 minutes. So there's a lot about negotiation. What does he need? What works for him? These are the things that I can offer. Let's actually do everything that we can to get this right.
Yeah. Okay. For the needs of time, I stopped that fairly prematurely. Was there anything more that you would have, like, if you can summarise what it would have been that the next steps would have looked like?
I would be telling Sasha, this is going to take a few minutes. I'd like to sedate him. In order to do that, we need to get a cannula in. These are the options. Play specialist. Maybe think about some nitrous to get the cannula in if that's going to work.
Yeah.
What does he need in terms of preparation? Is he someone who's going to? Would it be better if I rehearse the whole procedure for him so he knows exactly what's going to happen? Is it better if he's got some sort of outline? Does he want me to say we're about 50% of the way through now, or whatever?
Yep.
What's going to be helpful in terms of pacing for him?
Yep, great. And what would be your discussions about the expectation of mum as part of that procedure? So in some ways you've created this great space for Sasha to talk about what her child David needs. What do you need from mum?
Yeah, I think this is a really fascinating part of preparation for procedures, isn't it, in our role? So it depends how stressed. Sasha's fully on board with this. She's she's a parent who's there. I think it's about maybe depending on who else is available, could mum possibly provide some distraction? Is she feeling able to be in the room? If not, is there somebody else that can be?
Yeah.
And then sometimes if parents are really stressed and I think that their stress is going to create further stress for the child, then I might just give them a bit of a pep talk about, now listen, this is really difficult, but what I need from you is to just try to hold it together for the minute.
Yep.
Okay.
Right. Excellent. Sounds good. Sasha, any comments or feedback?
I think that was really good. I think that's the type of conversation I'd like to be able to have.
Yeah.
And when you've got time, it's great. And I think we have quite a lot of neurodiverse kids coming through our ED, and parents are really good at knowing what works. And some of them are just like, this is going to be an absolute disaster no matter what you do. And then, oh, fine. So what we can do for manipulation is then we just give them IM ketamine. What we do is we get them in a room and you chat them and you just sort of come upon them with it's like, can you get them down to their boxes? That's fine. And then you just pop that in there. So they don't know it's happened, and they normally have a really good outcome with that, and the parents quite like it.
Great.
Otherwise, we try and do like stepwise, and it seems to work.
Okay, brilliant. So I've taken Sasha out of role, so let's introduce her properly. In fact, I'll ask you to.
Hello, I'm Sasha. I'm one of the paediatric emergency physicians just down the road at the Women's and Children's.
If those of you that have been to lots of Don't Forget the Bubbles recognise Sasha, or have been to CODA last year, Sasha is often up on stage with me because she is the most brilliant actor as like a side hobby. She's devastatingly good. So let's give you a chance too soon. I was going to ask, in fact, all three of you though, to what extent do you signal to a child that you're about to inflict pain? And I struggle with this one at different times, so that's why I wanted to bring you out of role to ask you. In particular, I think about that line that parents use where they go, this won't hurt a bit, as I'm just about to put in a needle, and I go, oh, well.
I'm always really keen to not say it's not going to hurt, because it might be the case, but it very well might not. So I'd say, if we've got the LMX on or the MLO, whichever one you use, just say, this will take away the ouchy feeling, but you'll still feel this push, you'll still feel this, but it shouldn't be as bad as you feel. Now, what we can do is, depending on how old they are, obviously if they're little then it's different, but with a neurodiverse kid, what do you want to do? Do you want me to count? Do you want to close your eyes open, eyes closed? You're going to feel me touching you here first, and then I'm going to do it. Do you want me to tell me when I do it, or just tell you when it's over? And they're pretty good at going, just do it, or tell me, I need to know.
Okay, excellent. Anything to add to that?
There's a really useful thing that I was taught by a play specialist that I work with. I normally try to work out where children are with what I'm doing and what they think is going to happen. And the phrase that she uses for that is, what's the story you're telling yourself? And actually, lots of children are either telling themselves this is going to hurt, or telling themselves that they're not going to wake up for anaesthetic or something like that. And it's useful to find out where they are, and then I always give them honest information. So if it's going to hurt, I do tell them that. But I try to gauge that to be age and sort of developmentally appropriate.
Thank you.
Oh, just an anecdote of my first registrar year, so we're going back a bit, but which helped teach me the importance of communication and probably could go into the mistakes that we made. A newly diagnosed little girl with cancer who was going to have a lot of procedures, and this was one of her first needles that she was going to have, and I thought I did such a good job at explaining to her that she was going to have a needle, and I can't remember exactly the language I used around whether it would hurt or not, but we were using MLA, so it wouldn't hurt that much. And she was so on board, this little girl, and we went in and we were all set up, and then I pulled the needle out, and she looks at it and she goes, "That's not a needle, that's a pin!" She didn't know what a needle was. Like, she'd never had a needle before, so that was just a little random anecdote that.
Great, excellent. That's lovely. For some reason, my mind just goes, no, it's a unicorn horn. And I don't know why. I think it's been surrounded by paediatricians for a couple of days. Sasha, can I get you to move across onto the hot seat? Rob, if you could take Dad, if you could take your seat as well. Sasha is now a senior paediatric emergency physician who is at the end of an evening shift or coming towards the end of an evening shift. Rob is the father of a boy who is 16 years old, year 10, lives with you, and he has been brought in by ambulance unconscious and is starting to come up a little bit, was never needed to be intubated. He's been in a park having a couple of drinks, and what you suspect is GHB by the fact that he was so deeply unconscious and is now starting to come out of it, but he's not yet at the stage where you could have a meaningful conversation with him at any stage. Dad's just arrived because ambulance let him know that the son was coming through, but has given no clinical details at all. Does that sound like a reasonable summary of the case so far?
Yep.
Let's let you introduce yourself.
Hello there, I'm Sasha. I'm one of the doctors that's looking after Kevin. How are you doing?
Oh, thanks so much, Sasha. Yeah, Rob, I'm his dad.
Nice to meet you. What do you understand about what's going on at the moment?
All I know is that my son was heading out to watch some football as far as I was concerned, and he and his dodgy mates have been up to something.
So what we know so far, he hasn't woken up properly to tell me exactly what's happened, but I think he'd been out with some friends, it looks like, and he was quite asleep, so they brought him in, and we're just making sure that he's safe at the moment.
Yeah, well, it really worries me. I've never seen him like this before. I mean, what's he been taking?
So I can completely understand that you're worried. So at the moment, the main thing is to make sure that he's safe. So we've had a good look at him, we've been watching him, he's starting to wake up a little bit. It's going to take a bit of time, but he's got nothing to suggest he's had a bad head injury. I don't think he's got an infection. I don't think he's taken any medicine that means that I need to give him an antidote or anything. But he's obviously, I think he has. It sounds like the boys that came in with him, he's had something to drink, and that's okay. I know he's 16, and that's devastating to hear. If that's the first time that he's done it. But at the moment, he's safe. I can't tell you what he's taken, but, as he starts to wake up, we can go and have a chat to him together. I can have a chat to him by himself, because he's 16 now, so he gets to decide what he wants to tell you, but we can have a conversation about that when he starts to wake up a bit.
Whoa, hang on a second, Doc. Just hang on a second there. So for a starter, his mates have told me that he wasn't drinking that much to get him into this sort of state, so I know that he's taken something else. Can you do some sort of test?
It's not, so the way that he is, there's nothing that I want to test for right now. There's a finite amount of things that we can test for, and I don't think, looking at him and examining him, that any of the things that we could do a bedside testing for would actually yield any information that I think is necessary to find out right now. I know that's a really hard piece of information to swallow, and I do understand that.
Well, sure, I get that. You don't need to do anything right now, but he is coming home with me at some point, and the first thing I need to do is kill him. The second thing is kill his dodgy mates, but then when we get past that, I'm going to have some conversations with him, so I feel a little bit anxious about you saying that he's got the right to tell me what information he wants. I mean, here he is unconscious, you can do some tests, and you're telling me that either you're not going to do the tests or you're not going to tell me the results.
And I completely understand that that's a really, really difficult thing to hear. So I've got several things that I need to work out. I definitely want to be able to reassure you that he's safe, and he is, but also he's my patient and he's 16, so he's a young adult now. Whether or not you feel, obviously he's your child, whether or not you feel he's a young adult, especially given what's happened, he's still allowed to be able to tell you with regards to medical stuff. He's allowed to give us that information and tell me what he wants me to tell you. So my first duty of care, and I am very sorry, I know that's hard to hear, is to him and to his privacy. He is entitled to privacy, and I get that that's, you want to throttle him. I would highly suggest that you don't. And that's a normal way to feel when you're like this, and that will dissipate. It will dissipate. It doesn't mean that you shouldn't have a conversation with him tomorrow when he's feeling a bit more up to it, and you can engage in conversation. You never know, he may wake up and tell you everything. We don't know. How about we cross that bridge when we come to it? Do you think that's somewhere we can sort of start to work from?
We might agree to disagree there.
Fair enough.
All right, let's do the timeout on that one. Oh, that was so uncomfortable. But my God, you handled that well. It was uncomfortable because I just have been in that place so many times over the years, and I just never know what to say. But I'm starting to learn a little bit. How did it feel to you?
It's hard. It's really hard because Thea's so angry with her kid, which is completely understandable, and it's vast majority of the time is coming from such a good place because they are so worried that this kid is their little child, and then suddenly he's coming unconscious, acting like a feral cat, and it's like, what is going on?
A feral cat. Write that one down. The one that I once got asked was, what would you want if this was your son? And oh my God, that made me squirm, because I was like, I want to know what he took.
Yeah.
It's a really hard one. So why do you do the sorts of protection of privacy that you're doing? What's sort of driving that in your whole approach?
Because they're young adults, essentially. They're 16, they've got a right to privacy now, and you know why that changes over the course of their being like 15 and 364 days to 16 and 1 day. It's just the way that it is. So but they are entitled to privacy, and you don't want to break that privacy, because one day they may come in with an assault, or they may come in with something and they don't feel like they can tell you because someone broke their privacy for something that wasn't really necessary.
Yes.
And I think it's really important for young adults to understand that they can trust us and we're not going to tell on them. Because I think that's a lot of it, because they know they're going to be in trouble tomorrow.
Yep. And I wonder if that might not be part of the conversation almost with the parent, this is the reason that we do this, is to protect that sense of trust in the medical system, so he feels like he can come to us when he needs us. Mm-hmm. And I don't know whether that, I don't know, Rob, it's pretty hard to put you into a real role, whether that would have helped in any way or whether that would have just been like too much.
Yeah, it's interesting actually being in that role here and getting the pushback to information. I would, like, actually simulating that role and feeling riled up, I don't think there's anything that would have actually decreased that feeling of really wanting to know.
Yes.
Can I give a little anecdote?
Please.
Which you may not remember, but in January of this year, my 20-year-old was taken after a fall at a pub, head strike, unconscious, Royal Melbourne Hospital, adult hospital, and I was only on the phone. I was overseas at the time, and the doctor told me everything, and I was so grateful. Like, held nothing back.
Yep.
Yeah, and like really, so I know from from my adolescent health days what you should do, but I was so grateful to them for breaching every confidence.
Fantastic. Let's just for a moment enjoy wallowing in that hypocrisy.
There's a question over there.
Hi Ian, sorry I press-ganged Andy and stole the mic. Sasha, that was fantastic. One of the things that I often talk with the parents of adolescents about is to say that adolescence is a time of balancing risk and sensation seeking. And we know that young people who have these very scary outcomes as a consequence of their risk taking, that is, they burn their fingers, we know that they tend to head on a good trajectory there afterwards.
Yeah, that's true.
And so I often frame my consult with the family around that, because Rob, the way that you describe wanting to throttle your son is something I hear really frequently. But to give them permission to know that actually this is okay, because as you said, they're safe and the outcomes from here on out are quite good.
Yeah, no, that's really good. I like that.
Good luck.
Yeah.
I steal that.
So the other thing that you did a number of times was tried to escalate hard, and it felt like you couldn't. And I was wondering if you had that sensation that Sasha was heading off your frustration each time you started to build it up.
Do you know, I would have such confidence as a parent listening to that. I mean, really, I really felt as though my son was in very safe hands. Yeah, so you communicated that well, and I had that both sort of duty as a parent in my mind and what I was going to do, but I felt very safe for him in your hands. You communicated that very, very nicely.
Great, excellent. So that technique that you used, and you were sort of paraphrasing something similar, is like Rob would be like, "I'm really frustrated," and that sort of backflow of comment where you're like, "I reckon in your place I'd be frustrated too," is like getting a balloon and just pricking it. There's no way you can fight back against that. It's just like, "But I'm outraged." Yes. So would I be. "Oh, but I am." Yes. and I could hear that sort of going on, and I could watch Rob try to stifle a smile as he felt like he couldn't escalate anymore. So thank you both so much. Rob, we're going to put you now into the hot seat. Can you declare to the audience who you are? And as you do so, and Sarah's going to be mum, I can't see the timer on here. I don't know if it's on your monitor. Is it, Sarah? Is it on this one here?
No.
No. Is there a countdown timer anywhere that can come up on a screen? Or, Andy, can you keep an eye on it for me? What are we up to? Okay, cool. I'm trying to think of this. Oh, the circumstance. Yes, I do remember now. So you're on take, Rob. Actually, Rob, who are you? Did you introduce?
Yeah, I'm a respiratory paediatrician.
Fantastic. So as your role of a respiratory paediatrician, you've got this fascinating diagnosis, which you might have seen once or twice in your life, of bronchiolitis. And it's bronchiolitis in a child who is 11 months old, something similar. You've got also at home 2 other children. How old are they, Sarah?
2 and 4.
They both got asthma.
Mm-hmm.
And you've had a rough night of sleeplessness. And thank God you finally managed to go out and have a cigarette that you've been dying for all night. And you've just come back into the ward round. Your child's been looked after by your husband or by somebody else, grandparent, or so there's no safety issues here at all. But Rob's coming in to meet you for the first time. He's obviously will have built a rapport and gone through some history and examination as well. And you're filling in a couple of gaps on what the registrar did to the admission notes overnight. Is that an okay?
Yeah, so we will have had started off the conversation. I would have taken the past history, family history, and then I'm up to this point.
Let's go.
So yeah, thank you for telling me about that. I don't even know the name of your son. I'm sorry. Your child.
It's okay. It's Hugo.
Hugo. Sorry. Is Hugo taking any medications?
No.
No. Are there any known medication allergies? No. He's had his immunisations,
Yeah.
including influenza?
No.
No.
That's on the.
yeah,
I had he had the schedule ones.
Right. Okay. Yeah. We'll talk about influenza maybe a little bit later. And tell me, does anyone at home smoke?
Yes, I smoke. I don't smoke around him. I smoke outside usually, and my husband smokes as well.
Okay. And I know you know all about smoking and its effects on you and the children. Where are you on the spectrum from wanting to quit tomorrow to being a lifelong till death do you part smoker?
I don't smoke around the children. So yeah, I don't. Yeah, I've tried. It's pretty expensive. I did try to cut back. I didn't smoke much in pregnancy, but yeah, it's pretty hard.
It's really hard.
Yep.
Yeah. Is there anything I can do to help you to move one step towards making your next quit attempt?
Sorry, I'm really tired. What did you mean about the children?
Most parents understand that their smoking is in some way not good for them or their kids. We can talk in more detail about that another time. I don't think right at the start is when we need to go into detail.
Yeah, I smoke outside. Yep. Yeah.
Good-o. Well, we might move on and talk about something else because that's what we would do in practice.
I think that's my signal. I did say to Rob at any stage, just throw me a lifeline.
Sorry.
Okay, it's all right. So
Ian did say back off if it gets too.
Yeah. So that was an interesting one because Rob, you used the phrase, I know you know about the health effects of your children. Why do you use that phrase?
And that is because that's true. So for a starter, the literature is clear. 9 out of 10 smokers at any one time want to quit. And almost all of those 9 out of 10 smokers who want to quit know that their smoking is in some way harmful to their children or at least not good for their kids. So we that's the starting point.
Okay, is an assumption.
It's an assumption that they're going to be one of those 9 out of 10, almost all of whom know that their smoking is not good for them or their kids.
Yes. So if there is a follow-up question wanting the next part of how does it affect my kids, what would be your summary of what that effect is?
I never get asked that, to be honest.
Oh, okay.
So, and I would have that conversation or variant of it like at least 5 times every clinical day.
Okay.
I reckon, and it's again the literature is pretty clear that in certain name of respiratory illness that parent smoking is associated with a doubled risk of it. So either a doubled risk of the illness itself or a doubled risk of admission to hospital for it.
Okay.
Roughly.
And what is the likelihood of the children smoking because the parents smoke? So as they get older, obviously not the 11-monther.
No.
Unless you're doing weird things with your CPAP at Monash Children's Hospital.
That's a really good question because parent smoking is associated with a really significant increase of their kids becoming smokers themselves, with that effect ameliorated by quitting before the child turns 9.
Oh, okay.
Yeah, there's a sort of magic age there.
Yep. So nice bit of facts and figures coming through. How did that feel to you?
Yeah, it felt good. He's very kind. No, it felt fine. I think I was probably going to start to push towards, this is a virus, and we didn't quite get to that point. But no, that felt kind and appropriate and gentle for the circumstance because I was clearly tired. I was clearly trying to act like I was tired and stressed.
Yes.
So, yeah, I think it is a really difficult conversation to have in an acute setting without flogging a parent to feel guilty about the child in front of you at the time.
Right.
Yeah.
Which is, and what, you get pushed back essentially 1 out of 10 times because the parents are committed to their smoking, and that's actually the reality, in which case I do back off completely or move on to something else.
Great. So 2 things come across there. One is this element of kindness, and that was what I saw across the board as you communicated, it wasn't necessarily the words you used, but the kindness that came and the purity of intention that comes so clearly across. And parents uniformly talk about these discussions that are really challenging, where they hear not so much the word, but the attitude. And that can be really quite hard to teach and to model at times, but really hard to teach to people that don't have that naturally. So thank you for showcasing the body language and everything else that makes that up. There's one other question I was going to come back to, Rob, which is, it's almost like you're prompting a reflection and then backing off before you, I'm going to say, burn the relationship any further. Is that, why do you stop there rather than going forward into a progression of smoking cessation?
Oh, well, there are a few reasons why. The most important of which is that it doesn't work.
Yes.
If you push, and in fact, you can leave. And this again has been studied. You can leave a smoker more likely to be smoking after 12 months than if you'd said nothing if you do it badly.
Okay.
So it's a very skilled conversation to have, and you sort of, I think, need to know when to stop.
Yes.
And it's a brief intervention done well will leave a parent smoker more likely to quit at the end of 12 months, but a brief conversation or a sort of conflagration will leave them more entrenched.
Okay.
And so it's about like a sort of judo throw. You sort of use the weight of someone else to sort of maneuver them around. You don't have to push hard yourself. It can't be like that, because you can actually do harm.
And I think once you've initiated a motivation, or you've at least prompted some sort of transition between one part of Kolb cycle to the next, I think probably that, you know, they have links through to their general practitioner, they've got links through to their outside world, and you're hoping to initiate that follow-up and prompting it through with communication to the GP or somebody else.
Yeah.
Certainly, if it's a patient, if it's one of my patients, that's what I do. It's harder, I guess. But in your discharge summary, that might be something that goes through to the GP. Is can you chat to mum about smoking cessation? Is that?
Yeah, absolutely. So your role, our role, is actually just to help someone move that one step closer to the quit attempt. It's not to make them have the quit attempt. It's not to get them from where they are here to the way out there. It's getting them to move one step further along.
Great. Thank you. We won't do any more of this sort of role modelling, but again, thanks so much for our team for putting themselves out there. Applause completely appropriate. Yeah, that's fine, thanks. Actually, Rob, just because the chair will look terrible, can you put it behind the DFTV sign? That's the photographer in me now speaking.
It's all about aesthetics,
Thank you.
right?
So we're talking a little bit about prevention, and I think probably while we're on this subject, can I ask all of you to have a reflection of how to take on some of the ones that are slightly, I find, more challenging. One would be obesity in children, which we know is going to be linked to harmful ill effects, but is also linked to those discussions where you might have your concerns, and I'm wondering how you take that on. And Sarah, do you mind if I ask that of you first?
Eek. It's a really tricky one, and very interested if people want to jump in with how they do it better than me. And it is often tricky because it's often not about a child but a family unit. There are very strong genetic and environmental causes at play, so it can be very tricky. How do I go about it? I usually start to talk about the function, if that makes sense. So if I have a child who is obese, what are they not able to do? You know, are they not playing sport? Are they spending, I've got, you know, I won't talk about specific patients, but, you know, the teenagers who are spending a lot of time in their rooms, and, you know, sometimes the health effects of sugar levels and cholesterol, that some often talk about it from that perspective.
Yep.
But I think it's a little bit similar, interested in other people's thoughts on this, in that it is often something that families have thought about and don't exactly know how to address, or there are different ends of the spectrum on addressing it.
So when do you pick and choose whether to take this on as a topic or not? Because there must be times when you actually just go, actually it's not particularly relevant to this clinical presentation, so I think I'm going to choose not to go there. And sometimes where presumably it is, and I imagine particularly in a respiratory outpatients.
Yeah, my most recent one was 3 weeks ago. I saw a child for follow-up after she had a pleural empyema, and she was really overweight, 4-year-old child, like massively overweight, and I knew that I would have an opportunity, like the right moment would come up in clinic when I was following her up. And there I can still picture it. This child was sitting there on her mum's lap, and it was one of those t-shirts sort of that coming out over the belly that wouldn't quite fit in the clothes, and we took a weight, and I said, I'm going to do this calculation here, and I found the Z-score and then plugged the Z-score to sort of translate it back. So it was a child who would have been around about 1 in 20,000. Of the 80,000 children in Victoria,
yes,
40,000 would be girls, and I said that this one is probably the second heaviest of that whole cohort. And,
yes.
And so I thought that might lead to a conversation. The mum said, there's at least one who's heavier. and it was the conversation didn't go well, I have to admit, but and we'll have further conversation about it. We've opened the door to have that conversation, but it's that sort of ethical moment of what's our role, and if I just let it slide, am I just ignoring something that is going to take, well, we know it's going to take up to 2 decades off this child's life, as best we know it. And what do you do as a doctor in that sort of situation where you know something, and in the primary school, or preschool and primary ages, that's, you've got this opportunity, you can make a difference at that age.
Yeah.
Do you go there or not?
Yeah. And I'm curious as to whether, if we choose to ignore it, whether it's not just the case of it's like we haven't been there, but rather that we're giving permission that this is okay, because the big hospital doctor didn't mention it, so it's obviously not a problem, and yet the health effects are still there. And I think probably we have those opportunities. I mean, I get them in adult medicine all the time, where I've got patients with chest pain, where I'm taking a set of troponins and I'm waiting 2 hours before I take another set of troponins, and they've got all that time to reflect on life. And if they've got obstructive sleep apnea and hypertension and everything else, and I miss that opportunity, I might actually be reinforcing the fact, no, it's okay to keep on with whatever risk factors it is. It doesn't need to be, the increase in abdominal girth that's such a high risk factor, he says with utter hypocrisy. But I can't just ignore it. It's a chance to reflect, a chance to change. But it is a difficult one.
It's tricky.
Yeah.
You need to choose your time. Like, if they're fractious and they've been waiting ages, it's never going to hit well.
Yes.
And I thought I try and build it back to something that I found. So if they've got high blood pressure, it could be because they're a little bit anxious, but actually maybe have you thought about, how do they get to school? Do you think that you could get off a stop earlier or things like that? They're beautifully tall now, but if they continue, with this weight that is more than we would expect, then actually when they come to adolescence, they won't be as tall as you're expecting. So what we need to do now is give them time to grow into their weight. We're not asking them to lose weight, but that's what we're trying to do, and build it into something that they can do together. In fact, have you got a dog? What about walking the dog? Is that their chore? Or things like that. Or if they're really big, and then dose adjusting like pain relief. So this is the reason that we do this, and have you thought about, if they've come in like with a broken arm and it's got absolutely nothing to do with it and they're not interested, then there's no point, because I think you'll just hit and they'll just be the wrong point, and they'll just, it's not going to go anywhere.
Great. So looking the other way, and Becky, I might look towards you with this one. What does the conversation look like where you're risk screening for an eating disorder of some sort? So backing away from obesity towards sort of, trying to screen, or picking up a red flag for an eating disorder?
So I think for me in ED, that sort of screening often comes as part of my general assessment, often kind of touch on that as part of my head's assessment, and thinking about conversations about, I suppose I probably ease into the more difficult parts of these conversations, and I will have opened the door by having, general conversations about who are you, what do you enjoy, and what are your aspirations for the future, all of those kind of things. And once I feel that I've got a bit of a rapport, then there may either be some questions about, what sort of activities are you doing, and trying to gauge whether young people are using excessive exercise as a means of weight control, and thinking about that. It could be, I guess, a question about, is there anything that you don't like about your body, or something like trying to think about that. I think there are various ways that I might ease into it. How are you in terms of your physical health? Has there been any particular changes in your weight over the last little while? Sometimes it can come off the back of a few questions about home and family and daily routine, and what does family mealtime look like in your house, maybe. Who's there? Do you eat together? What sort of thing? Who decides?
Do you routinely remove parents at some stage during an ED consultation from adolescents? Just ask them to just...
Always.
Okay, Sasha, you're nodding as well. You do?
Yeah.
And make it routine so it doesn't seem like we do this.
Absolutely.
And this is why we're doing it.
Yeah.
Okay.
And that's part of, I normally, my general practice is to have them in for the first bit, because everyone's clamouring to get in because they've been sat in the waiting room for ages. And often, parents are in there for, often the medical history for the immunisations, because the kids sometimes don't know that. And then, but I usually say, what we're going to do is start off with all of us in the room. Then I'm going to get you to sit outside in the waiting room for a little while we have a chat amongst ourselves, and then you can come back in afterwards.
Yeah, great. That normalisation sounds so important as a way of getting parents to buy into the fact that there's going to be a period of time where they're going to be outside the room. And in fact, you usually get this look of relief, don't you, from the kid, as they get the chance to open up on what is really going on. Whether it's physical symptoms that are a bit embarrassing, or whatever's going on in life outside that.
And so I generally say, that's the time when I do my heads assessment and do all of that kind of chat. And at the end of that, there's usually something for me about, lots of young people your age don't get to come and see a clinician often. And so I always ask people whether there's anything else that they'd like to discuss while they're here. Is there anything else that's been on your mind that you think that I might be able to help with? And all sorts of stuff comes out then.
That is brilliant. Okay, so that's one for me to write down and remember, is actually not focused questions, but just a big open. Is there anything else? Well, you got this opportunity. Mum and Dad are out of the room. Go for it.
Yeah, and I've given them, the confidentiality chat plus the disclaimers about confidentiality, so the door's open. It could be anything.
Okay, so the confidentiality agreement is part of that as well. I reckon it helps that you look like you and I look like me, and that you probably are a bit cooler to the average teenager than I would be.
Oh,
I'm just guessing.
Only at the moment. Once my hair goes back to not being this colour, it's over.
Make the most of it. Excellent. Now, I did threaten you with this question about what is the most embarrassing communication problem you've had, and what did you learn from it? And I don't know if you've had a chance to reflect on this one. Who's going to go first? Rob, you're sort of smiling to yourself. Oh, by the way, I know Rob very, very well. So he and I were mates in medical school, and we've been best friends for 30 years or so. So we do know each other quite well, and I'm likely to tease him at some stage. So forgive that. In fact, I know all of these people very well, I've got to say. So Rob, what's yours?
I was really trying not to make eye contact there.
I'm really happy that you did.
Oh, golly. If I can sort of sidestep that a little bit and just talk about where I regret still to this day a poor sort of episode of communication in a way I was part of on a ward round, and it's stuck with me because it's more than 20 years ago, but I wasn't brave enough or assertive enough to actually step in and do what I probably knew at the time I should have done, and just to de-escalate. And that was a smoking cessation intervention gone wrong, where it just escalated and escalated, and the consultant didn't back down and the parent didn't back down, and it really became quite heated, and it was just so obvious that neither party was going to agree with the other, and that's all fine. You actually need to move on and deal with something else. And I didn't intervene when I should have, and really to this day I know that I should have.
Okay. Well, we saw what you learnt from it because we saw it in action, so I'm not going to ask you that question. Sarah?
Can we not let this go live to air because there will be real patients discussed? I guess in two different, that you've reminded me of, one recently where I escalated too much in a patient where there was some Munchausen's by proxy type, maybe not quite that extreme, but certainly we thought that there was parental obstruction, and I just felt myself, the sort of feeling you get when you're in this scenario. I felt my heart rate get, higher and higher, and the mum was just sort of playing off me to a point where a gastroenterologist had to say, okay, we're stepping out now. And that is just not me. And
Yes.
I think being able to recognise your own, none of us work in a vacuum, right? We all bring our own biases, our own backgrounds, our own life experiences to these conversations, even if we've learnt the perfect way of communicating. And I don't know what it was about this scenario that just made me have sort of a visceral reaction that was clearly, and we're just clearly playing off each other in a way that I'm not proud of at all. It wasn't terrible, but it wasn't my usual style. And so we just sort of stepped out. And it was in front of the child. Okay, so that was the worst bit.
Yep.
And so we all stepped out of the room, we all took a deep breath, and it was okay. But I got that really wrong, that scenario, and learned a lot and had long discussions afterwards, debriefing. Right. And then I guess the flip side is when you do open up the conversation, and I think this is what I was probably getting wrong in the answer to your obesity question. One thing you've got to do is just pretend you are cool with all of the things, and that if you're talking about obesity or whatever, it's scientific, it's matter of fact, you're talking about it. And just sometimes the teenagers do come out with things where you go, oh, okay, right, yep, no, I talk about that all of the time. And I remember, I don't know, shall I go there? Shall I?
Definitely.
Anyway, I just remember, and we've all got these stories, so it's not that, but having the one-on-one parent out of the room and the young teenager asking me if marijuana could cause impotence because he was having that experience. And I was like, oh, okay, that's where we're going, right? Like, it was just so out of the blue. And then I thought, well, this is going to open up, like, the parents just outside the room, sex education, drug use. I'm like, this is gold. But yeah, okay, I'm cool with this conversation. Yeah. So I think
Yes. Okay.
Yeah.
I have used the phrase, you'd have to try pretty hard to shock me. I've been working in emergency departments for a long time.
Yeah.
And then you go, oh, it worked. Nice.
Yeah.
Sasha?
I think one that I handled poorly, and I was a parent that had twins and they had bronchiolitis, and the grandma kept going on about the cough and kept interrupting sort of the flow. What I was trying to get at was actually they were breathing and they're feeding. And it was early hours of the morning, which is not an excuse, but more of an explanation of how I probably wasn't as on board as I should have been. And she just kept going on about it. And I was like, oh, I'm not concerned about the cough. What I really need to know is this. And what I should have said is, we'll come back to the cough. I want to just go to this part and then we'll circle back. If I don't, please remind me. And the reason they were so perseverating on this was that she'd had a child that died from whooping cough. And that didn't come up, so they were really, really upset. These kids were fine and they were feeding and that was not a problem. But their overarching concern was actually, is this whooping cough? and I did not get to it, and that was really poor. And it's just because she kept interrupting me and I kept losing my train of thought, and it's just, it was really bad form of me. So I've sort of, if people keep interrupting, if I'm trying to get to something, I always say, please, I'll circle back to that. If I forget, please remind me, I will address that.
Yes.
But, and another one was explaining SVT to a father that was actually a cardiologist. That was awful. Never been so embarrassed in my life. I didn't know they were cardiologists at the time because it would have been much better, but I was so mortified. There's these top chambers and these bottom. Awful. Absolutely mortifying. Yeah, it was terrible.
Mind you, I reckon they deserve it. I reckon you're not going to go in there as a cardiologist and SVT and not declare you're a cardiologist. That's a double whammy of identity to me. Excellent. So again, that reminder about, the cough's important. Why is the cough? Actually, then it becomes a curiosity. Why is the cough so important to you? And that might sometimes elicit, and sometimes it takes a bearing, or it comes up next day as these guys do their ward round and discover the things that we've missed under the pressures, or because they finally decided to share later on additional information. Becky, your embarrassing moment, if you might, and what you learned from it.
I think I was kind of flicking through a catalogue of embarrassing moments in my mind, but there's one, and I still can't work out exactly what went wrong, but I'll tell you what I've learned from it at the end. I was having a conversation with a grandmother. Her granddaughter had been brought in with some horrific facial injuries that could only have been caused non-accidentally. And we were going through the whole child protection investigation. They were in hospital and all of the things were happening. And I, took her to one side because she wanted to have a conversation, and I had been through all of the things. This is going to take time. These are all the things that we need to do. At the moment, our role is to gather information and all of the things. It's going to feel incredibly invasive. And what I was trying to say was, I know it's awful, but I just need you to work with us for a few days until we get to the end point. And I said, what I really need you to do is to just bear with us for a few days while we work our way through this process, and then at the end we'll get where we need to be. And she lost it, and she stood up and she started screaming. She said, bear with me? How could you use those words? And I was like, God, I don't understand what I said.
Yeah.
And I said, I'm so sorry. I genuinely didn't think that would upset you. I'm really sorry. And I walked it back. But I still don't understand what was wrong with those words. But what I've taken away from it is that there are certain phrases that we use that must be incredibly triggering for people. One of the things that's triggering for me is that when people say to me, I'm sorry that you feel that way. Because what it means is, this is all on you. You just feel like that. It's got something to do with me. And so I'm massively triggered when people do that to me. And clearly that was a trigger for her. And I think we just have to bear that in mind sometimes. And sometimes we can't bear that in mind. I've done it again, haven't we? We can't take those things out because if I start talking like I'm not myself, then I can't do the job. But maybe we all just need a way of de-escalating from that.
Okay. My mind is just full of all these dad jokes at the moment about grizzly bears and things. So, and I'm just showing that I have got frontal control because I won't say that out loud. Anyway, yes, I don't understand what you did wrong. But sometimes it's a mismatch between your patient and their frame of reference and yours, and a phrase that seems perfectly innocent triggers off something, and sometimes we want to follow that up and say, do you mind just explaining to me what that phrase means to you, or how I've managed to offend you so that I can avoid it in the future?
Yeah. So, sometimes I've caught myself and I've caught them go, ooh. Like I was talking to some parents of a baby who had a fever, and I said something along the lines of something, or and we usually find that this is okay or whatever, and I could feel them go, and they needed me to be far more certain than that.
Yes.
And I said, okay, let me just check myself, because I don't think that landed. I used the word usually when I actually meant I'm sure in your baby's case.
Yes.
And so if you can catch it in the moment and then walk it back, it's easier.
And I think that's a skill of mastery in some ways. And in fact, I think all of you touched on this as we talked before this session, about the fact that not every sentence is perfect. And part of what you're doing is monitoring the content and the reaction. And all of you, I suspect, have said the wrong sentence at the wrong, like just an absolute clanger, and just dropped it in there. I know I have. And sometimes that is the right approach, of just apologising and not, I'm sorry if you were offended, which obviously is triggering to you, and I'm in hitting distance, but I'm sorry, I've just said something really clumsy. Let me rephrase that. I like the way that you monitored, actually, I'm just going to reframe it. I'm certain in this case it's not this.
Yeah.
Okay. Thank you. I think it's really refreshing to hear, if you're building up your mastery of communication, the fact that we just get it wrong so frequently, and that's okay. No one expects a perfect conversation, and removing that expectation from yourself is sometimes helpful. It just reduces the intensity of the experience and the amount of cognitive load that you're under if you give yourself permission to occasionally get it wrong and pick it up in the moment and correct it. I'm trying to think the other topics that we talked about. Oh, Sarah, you said that you hated discharging people home without a diagnosis.
Oh, man,
Now that's bread and butter for Sasha, I think.
You're
So
just
I'm gonna-
psychoanalyzing me today.
Oh, I'm so sorry if you're offended.
We're sorry you feel like that.
Can you? 'Cause this is probably your bread and butter a little bit more. So how do you have this conversation?
So I spend varying amounts of time with how I feel, how anxious the parents are about something. But oftentimes it's like, look, how I frame it is, I'm really sorry I can't tell you exactly what they've got, but what we've ruled out is the nasty things, or we've ruled out a urine infection. So we've ruled out the things that are really important that I need to treat today. And then I give them good discharge, like red flags and things like that. And then we're really lucky. We've got discharge liaison nurses, so nurses that can do a follow-up phone call, or they can even do like a visit. And we have that 7 days a week. So we're really, really lucky that we have that. I know not everyone has that, but if they don't, then you just give them really good advice about it. And then sometimes it is, I'm sure this is a virus, and now coming from COVID, everyone's going from swabbing every child that was hot or snotty or had gastro to, doesn't really matter. And that's quite a disconnect with, well, I want to know what the virus is. And it's like, I don't really care what the virus is, it doesn't really matter. Which is obviously not how I frame it. And the mask helps, so I've only got to control my eyes. But and just and then sometimes it is a negotiation. These kids, like these parents, are really worried, or they had a really bad infection before, or they feel like no one listened to them. And they ended up with this empyema, and actually probably they did have recurrent viral infections, and then that last one actually was a horrible pneumonia. So you have a bit of negotiation, and it's sort of. I want bloods done. So I'll sort of ask them, well, what is it that you're looking for? Not in a disparaging way, but to say, look, because certain things will tell you stuff, but most of the time it just tells you there's inflammation there, and I can tell you they've got an infection. So the number doesn't mean anything, but I think maybe what would be more useful for you is maybe we'll do a urine test and check that they haven't got a urine infection.
Yes.
Even though 1 day of fever, you're allowed to be hot for a day, or I'm sure this is a viral pneumonitis, like they got bilateral chest signs, but if that's going to make them feel better, yes, it's a dose of radiation. It's not a lot. It's like an extra day of being alive, or however many days, I can't remember now. But and then say, there's no point in you being at home and worrying about it. If I can do something today that is going to make you feel a bit more comfortable, and then they're like, well, actually, no. If you think that it's okay, then that's fine. But they've been heard, and I think a lot of it is that. But I will say, most of it is coming back to, I've ruled out all the things that I really need to do today.
Yes.
And just giving them
Okay.
the empowerment to come back.
is the expectations different if you're in a tertiary admission on a ward, or is the conversation much the same?
I think it's probably pretty similar.
Yep.
Yeah, I mean, maybe there's a different pre-test probability, for want of another term, because by the time our emergency colleagues have admitted them, they're probably there's often, not always, often a bit more to the story. They're sicker than the ones that you've sent home. And yeah, managing uncertainty with families is difficult, and it's difficult with ourselves as well, which is what we had talked about, and sort of particularly if you are still a little bit worried yourself, but you're not so worried to keep a child in hospital any longer, to have that conversation with a family to manage their uncertainty, while also managing your own is probably a whole session's worth.
Yeah, okay.
If that makes sense.
No, that's fine. I'm conscious of that ticking time, and there's one topic that I did want to get to, if it's okay. Rob, you've got a particular expertise in the Indigenous community, and it would almost seem like a waste if we didn't touch on that. Do you mind going through a brief summary of the background of where you've worked and how you've learnt the differences in communication with that community?
Sure. Thank you. So I worked in Central Australia for 6 years, and that was 6 fantastic years. I loved working there and in that field, and I've had different roles in Aboriginal child health ever since, going to urban Aboriginal community-controlled health organisations to do 1 day a month or thereabouts, clinical care, just in bodging my way through general paediatrics.
Yes. Okay. So where I work, I don't have access readily to Aboriginal liaison workers or anything similar. So what would be the sort of tips for me as a very obviously white Caucasian doctor that might assist me in communicating across to that group?
Wow. Firstly, there are lots of people in the room who have expertise and more current experience than I do. I saw a colleague from Royal Darwin, at least I think she's here in the room, and there are others who have other sorts of experiences. I think we all need to actually educate ourselves in general terms around Aboriginal communities and Torres Strait Islander communities in Australia. I sort of feel as though we have a special obligation to those communities, and a special obligation to educate ourselves, and there are some fantastic resources around, and I feel like an evangelist for Marcia Langton's book Welcome to Country. So I have to say I've bought copies and given them to other people, and think that if you just sort of flick through and understand a little bit more, that's a sort of a prerequisite. And the second thing is just bringing yourself to the consultation, and bringing your authentic self, recognising that you're going to get a whole bunch of things wrong culturally, and I think there's probably not a mistake that I haven't made. I think I've made them all, and generally found the kids and families to just be accepting that he's someone who's trying to be helpful and mucked up some of the communication, and that they sort of roll with that. I don't think any of those communication errors are game-changing or relationship-ending.
One of the things that I touched on with you at a different time was about the importance of listening and story, and that a highly compressed history on a timeline of I want this benign mark and this, and how many days did you have this symptom for, is not necessarily going to work in a culture where story is important, and community and culture are important, and family is so important, that you're in for a good story and you might as well settle in and enjoy it rather than fighting it. I don't know if that's a generalisation that holds true to your experience.
Not for everybody, but for a lot. And that's the one thing that the biggest thing that I've learned from Aboriginal child health is being a better listener, and it is really, really important, or at least it was for me in Central Australia, and I've taken that forward. And I can give you countless examples. In fact, I can remember one where I used to have this pattern. I don't do it with every single patient, but I used to do it with every single patient who's old enough. What are you going to be when you grow up? And then I used to say to the parents, what do you think the child's going to be when they grow up if they weren't able to answer? I used to ask it with every single one, and I can remember this one where I asked the question, the mother didn't give me an answer, which was culturally appropriate. And I just thought, stuff this, I'm not going to be the next one to speak. And I'm, like, when there's a silence, someone normally fills it. And so they normally fill it when you get discomfort. Well, I discover what comes after discomfort, which is pain. and I really was not going to be the next one to speak in that room, and I didn't care how long it was going to be. And it was almost like, it was long, and it probably was measured in minutes. Could have been 4 or 5 minutes, and I just sat there.
Yeah.
And the mother said, he's probably going to grow up and be a drunk, and this is about a baby.
Oh.
And both of us burst into tears. Both of us burst into tears at that moment, and it was an incredibly powerful experience for me, learning, but an incredibly powerful way of opening the door to what was going on. And that, I can't remember what the consultation was about, but it certainly went in a completely different direction. If you've got a mother of a baby who has that vision of her child's future, oh my gosh. And there's no way anyone could have discovered that just by the normal sort of question and answer.
Yeah, great. I think probably as I look at the time ticking by and realising there's 2.5 minutes or so to go, that might actually be just a wonderful place to start to wrap. In this idea of silence and space and listening and curiosity seems to be the key to so much of what we've been discussing today, and an appreciation as we as a group have got to listen to the expertise of years of making mistakes or building or role modelling on the people around you, to be able to contribute that. And certainly I've learnt a great deal from you all today, and very much appreciate it. So if our audience feel like it would be appropriate to clap, you've got some good practice at the start. I reckon you could exceed the noise there for this group. At least try anyway.
Thank you, Sarah, Rob, Sasha, Becky, and of course, Dr. Ian Summers. Another round of applause, please.
Thank you.